There's a common belief in implant dentistry that porcine xenografts are better than bovine ones. You hear it repeatedly until it becomes accepted as truth. But very few people stop to ask a more important question. Better in what way and according to whom? After 30 years in surgery, I've learned that biology drives success. This channel explores implant and oral surgery, how the body responds, how it can improve healing, and what the science shows, and how disciplined surgical execution turns evidence into results. Welcome back. Today, we're covering porcine versus bovine bone grafts from an immunology perspective. This video is not about brands, marketing claims, or proprietary manufacturing processes. We're not comparing purification temperatures, protocols, or packaging. Instead, we'll assume that both a porcine and a bovine xenograft are properly processed, and then we'll focus on what actually determines success once these materials are placed into the body, how the immune system interprets them, how it sees them. Anatomy matters, but it's not the answer. Yes, anatomical features like porosity matter. Porosity allows blood infiltration, space for vessels, and bone ingrowth. But when porcine and bovine grafts are processed responsibly, porosity alone does not explain different clinical outcomes. If anatomy were the deciding factor, results would be predictable and almost identical. So anatomy sets the stage, but biology writes the script. The first cells to interact with the bone graft are not osteoblasts. They are immune cells, mainly macrophages. Macrophages don't ask whether the material is also conductive. They ask whether it is familiar, safe, or something that needs ongoing surveillance. Even after purification, a xenograft retains its collagen framework. Collagen is not just a substance, it has a three-dimensional ultrastructure, a triple helix, fibril spacing, and cross-linking patterns. Immune cells recognize shape and organization, not marketing descriptions. Porcine collagen is structurally closer to human collagen than bovine collagen. That structural familiarity results in less immune scrutiny, earlier immune resolution, and a smoother transition to healing. Alpha-gal epitopes, silent immune friction. Alpha-gal is a sugar structure present in most mammals, but not in humans. Because we don't express it, humans naturally carry antibodies against alpha-gal. This is not an allergy, it's not a rejection. It's low-grade immune awareness. Bovine tissues tend to retain a stronger residual alpha-gal signal even when well processed. Porcine tissues tend to be immunologically quieter. That difference doesn't cause dramatic inflammation, it causes slow remodeling, prolonged macrophage activity, and fibrotic tendencies in susceptible hosts. Proteins are decorated with sugar chains, glycosylation patterns. These sugars act like an accent, as I have. The immune system recognizes them immediately. Porcine glycosylation patterns are closer to human patterns. Bovine patterns are more evolutionarily distant. That subtle difference can keep the immune system alert longer than necessary. When processing is equal, porcine and bovine grafts don't differ because of particles or porosity. They differ because the immune system interprets them differently, early, quietly, and decisively. The immune system evolved to recognize patterns it has seen before. Porcine tissues have been used in medicine for decades. Heart valves, membranes, skin substitutes. That evolutionary and clinical familiarity matters. Familiar patterns allow the immune system to stand down sooner and regeneration to begin. Once immune tension resolves, angiogenesis follows. Without blood vessels, bone formation and healing never truly begins. Most graft failures are not mechanical failures, they are vascular failures. Bone doesn't fail because it's weak, it fails because blood never arrived. So porcine versus bovine is not a marketing debate, it's an immunology decision. When processing is equal, the real difference is how quietly the immune system accepts the scaffold. Predictable grafting is not about particles, it's about host response. If you're an implant dentist who wants biology-driven, complication-proof surgery, please subscribe. Every week, we break down one clinical problem you've already seen in your practice. Where do you see grafts fail most often? Early inflammation, delayed remodeling, or late volume loss?